quite similar. One of the things I'm going to look at is, I suppose, the formation of a protocol for vascular occlusion. And I'm not so modest enough to think that anything more than, I'm going to call the Dublin Protocol because people, maybe somebody in the room will remember it when they're in a sort of problem situation. This is the sort of thing that happens, and this is a colleague of mine in South America recently that we followed this situation. So the guys haven't given me a remote, so I'm linked, unfortunately, to the stand. So why is this happening? And if it does happen, what do we do? Is it happening because just stuff happens? On a normal day we go into the office and suddenly this is the worst day we've ever faced? Or is it happening because of something that we're doing wrong? Now, something we're doing wrong could either be the product or the doctor. Now, the background to this, I suppose, is that it's on the increase, but we don't know it yet. Is it also because the products are on the increase? And they really are going up. And if you even see the way that dermal fillers have gone up, it's increasing at 13% per year, whereas Botox is only increasing at 3%. We know ourselves that the corporate is really driving this for sales, and as a consequence, we have a situation where it also could be something that the corporate is doing wrong. I'm only putting it out there that certainly lidocaine recently has been added to all our dermal fillers. Even without a permission, suddenly it's in everything. Now just consider for a minute that lidocaine is a vasodilator, so it's quite possible that what we're doing is we're creating a scenario where all these fillers that contain lidocaine, we could be setting up our arteries like ducks in a row, just waiting to be shot by our needles. I'm only putting it out there, I'm not saying it's the cause. Now, adverse reactions like these, thankfully, are rare enough, and I don't want some new injectors in the audience to go home feeling that I'm never going to inject again because this sort of thing is going to happen. They're not too rare that in this patient's situation, your disease is so rare that we're going to name the disease after you. But certainly, I've seen probably 20, some of them my own, one or two, most of the ones that were sort of sent in to me. Vascular complications will go through a series of events. You get blanching. If you get pain, consider embolism. Libido pattern, blue-black discoloration, blister formation, and this is over a period of days to weeks. So who throws the trampoline? Plastic surgeons, and I suppose people like myself, have to end up correcting these problems. This is a friend of mine from California that got injected and had this type of problem. One to watch is the labial artery. Everybody tends to forget about it. The labial artery is just in this position here, at the wet-dry line in the posterior aspect. People often inject there to get the bee sting effect, and of course, if you do, you can end up with this. This is a paper that I wrote for Prime some years ago, and during it, I was just putting in some radius there. Within a few days, the patient had this level of necrosis. Thankfully, he was fine. This is a patient that was sent in to me in Dublin who had radius injected in their face, and thankfully, actually, they didn't come out as bad as it was presumed. So why does it happen? This is an arterial embolus that will happen with sort of hyaluronic acid within it. The superficial arteries of the face was beautifully shown to us by Philippe earlier. I don't really have to go into that again. And if we consider for a moment, there's two different effects. One is when a small bolus goes into the artery, and as a consequence, I almost would like you to consider it like a road traffic roundabout. If the small bolus goes in and there's any collateral circulation, it probably is fine. If it goes in and there's none, then you're going to end up with some level of necrosis. So if we consider this power of renal junction, when it's blocked on the entry route, Everybody considers it as purely arterial embolization, but the back end of it is the vein, of course. And if the vein is blocked, then nothing can go through the artery. And as a consequence, the type of patient that will present to us a day later that will have had hyaluronic acid, who presents with some level of vascular compromise, is most probably venous rather than arterial. That's what I think, anyway. I'll go through it more in a moment. Now, obviously, if there's no collateral circulation, we end up with this type of picture. The second one is the one that our first speaker, Nimrod, beautifully demonstrated for us. And that is a situation where a different type of thing happens. Could I have some sound on this now, please? Is there any sound? Okay. So this is the one that sort of tries to get out the other route, and unfortunately ends up in a situation where the patient can go blind. That's not to scare anybody, that's just to remind us that if the filler bypasses the tributary, it can make its way to the other sites down the line. So what do we do? First thing to do, don't panic. Discontinue the injection, massage the area, heat the area, get some warm packs, go to your microwave with some towels, heat up the area. Understand why it happened. If it happens before you and you get blanching and pain, then it's going to be an arterial embolus. If it appears the next day, then I suggest that it may be vascular compromise for another reason. I advocate in these patients something slightly different. Give them a bolus of dexamethasone, 10 milligrams intravenously straight away. If it's venous, secondary to the expansion of the hyaluronic acid, it's going to reduce it. But also, even if it is arterial, the inflammatory setup that happens just prior to necrosis will be aided by giving some steroid. Is it reversible or not? There is a good case for just having the reversible fillers only go into the nasolabial area. I know some companies might not be saying that, but I suppose collagen and hyaluronic acids are both reversible enzymatically. The rest aren't. Everybody should have hyalase in their cabinet and know how to use it. And most certainly people who do remote clinics should have it as part of their normal thing. Now, anybody who's ever used hyalase will know that it's actually quite painful to use. And as a consequence, I advocate mixing it with lidocaine. Make sure you don't mix it with lidocaine and adrenaline, or obviously you'll make things worse. So lidocaine and hyalase mix together, and what I suggest you do is take 1 ml of the 1500 units, draw it 0.2, so you're down to 300 units, mix it with 0.2 or 2 ml of lidocaine, and then each 0.1 ml of that is 75 units. The literature would tell you to use just 30 to 75 units, but I actually advocate using 10 times that amount. You'll do no harm. I've used it, and certainly all evidence points towards the fact that it probably won't reduce your own hyaluronic acid or collagen to any great extent. Remember also to inject perivascularly, because you don't have to go back into the vessel. It will absorb through the wall of the artery, and so if you hit every hour 4 different shots of 75 units, and do that until the compromise has gone. Nitrates. Everybody says to use nitro paste. That's fine, but I mean the patient has to go to bed and go to sleep. They can't be waking up every hour to put it on. So I advocate strongly to add in Viagra. It'll last for 24 hours, or Cialis can even last for a few days. Sorry, this microphone is terrible, it keeps falling off my head. If you are using nitrates or nitroglycerin, be careful also of patients with cardiac problems, and of course people with anemia. And this can also drop your blood pressure. I've seen one situation that I'm going to mention tomorrow on my neck nerve case. Thankfully it wasn't one of mine, but I was treating it remotely. The patient actually had a syncopal episode, hypotensively secondary to a nitrate, and then her husband panicked and called for an ambulance, and but it was a doctor's patient. I'll run it through it tomorrow. Viagra, as I said, add in, or Levitra or Cialis, and this will increase your GMP, cause smooth muscle relaxation, dilation of the vascular wall, and obviously watch patients that have potential for heart disease. In terms of versus protocol, as I said, mix the high-lays with lidocaine, give it in shots of 75 units at a time, and this is purely just so that people possibly will remember sometime if you're stuck. I mentioned Dublin, not to put it out there any more than just discontinue the injection, understand why it happened, use a bolus injection at the zone if it's venous, lidocaine and high-lays to add them together, inject multiple areas, and use nectar paste or